Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can take a detailed look at avoidant personality disorder. So this is really a comprehensive review. I'll not only look at the definition of the disorder, but a quick look at the history and a more detailed look at comorbidity, etiology, and treatment. I'll refer to this disorder as Avpd. With Avpd, we see a pervasive pattern of social inhibition, feelings of inadequacy, and being hypersensitive to negative evaluation. People with this disorder view themselves as unwanted and isolated from other people. The key to understanding Avpd is really to look at the reason why individuals with the disorder avoid other people. And this will become more clear when we look at the symptom criteria for the disorder. Now, Avpd was introduced in 1980 as a diagnostic classification in the DSM-3, the Diagnostic and Statistical Manual, version 3. And really, we see here in this version, it appears the mission was really to differentiate this disorder from schizoid personality disorder, and I'll talk more about this later on in the video. Originally, social anxiety disorder could not be diagnosed at the same time as Avpd, right? So that was another way that this disorder was differentiated. Now, of course, they can be comorbid. Somebody can have both disorders at the same time, and I'll talk more about that later as well. So let's take a look at the disorder as we see it defined in the current version of the DSM. This is a cluster C personality disorder, so the anxious, fearful cluster. It's in the same cluster as dependent and obsessive-compulsive personality disorders. We see 7 symptom criteria listed here. 4 or more are required for a diagnosis. So, number 1, avoids jobs that involve contact with a lot of people, and the reason somebody would avoid the jobs would be a fear of criticism, disapproval, and rejection. The second one, they don't want to deal with people unless they can be certain that that person will like them. Third one, they move very slowly in romantic relationships because specifically of a fear of shame and ridicule. Symptom 4, they're preoccupied with being criticized or rejected in social situations. Symptom 5, they feel inhibited in new interpersonal situations, so like new relationships, specifically because of feelings of inadequacy. Number 6, they view themselves as socially inept, personally unappealing, and inferior to other people. And the last symptom criterion, number 7, due to fears of embarrassment, they're reluctant to take personal risks. So we see a lot of themes here, looking at the definition: inadequacy, inferiority, fears of rejection, and criticism. And of course, all these move to someone being isolated. Now, avoidant personality disorder is an interesting personality disorder in terms of how it's viewed by the mental health treatment community. It's often thought of as a low prevalence disorder that causes difficulty for the person who has it, but not as much difficulty as we see with other personality disorders. So it's thought of as less severe. For example, many clinicians would say that borderline, antisocial, or paranoid personality disorders would cause more problems in somebody's daily life. Let's take a look at this perception. The prevalence of avoidant personality disorder is 1.7% in the general population, although the actual prevalence might be a little bit higher. Many researchers believe that Avpd is either the most prevalent or the second most prevalent personality disorder in the population. So usually it's between obsessive-compulsive personality disorder, OCPD, and Avpd in terms of which one's really the most prevalent. And of course, both of those are in the same cluster, cluster C. Now, that's in the general population. In terms of the outpatient population, so people seeking mental health counseling, Avpd is a comorbid disorder in 15% of that population, which means it may not be the primary focus of treatment. So with comorbidity, this means that 2 or more disorders appear together. So somebody may have depression and avoidant personality disorder, but they might be mainly treated for the depression. So this is one of the ways I think that avoidant personality disorder really gets overlooked a lot of the time. The clinicians are working on symptoms from other disorders. So this takes care of the idea of prevalence. We know it is a highly prevalent disorder, But what about the idea that it's really a less severe disorder? Well, when we look at the 10 personality disorders, avoidant personality disorder is actually associated with the highest level of impairment in daily functioning. We see difficulties in areas like mental distress, so there's a high level of mental distress, low self-efficacy. It's associated with a lower level of education, lower income, and being unpaid for work, right? So just working and not receiving any pay. It's also associated with somatic symptoms. So going back to this idea that the mental health treatment community views AVPD as uncommon and really not that serious, we see this as a misperception. And I think this misperception occurs for a variety of reasons. I'll look at 3 here. First one, AVPD is not well understood. It's also understudied. So we don't see many articles on this disorder compared to other disorders like borderline personality disorder or narcissistic personality disorder. Second reason, the nature of the disorder itself. Many people who have this disorder obviously avoid other people. So that would include treatment professionals. The third reason, there's a lack of dramatic behavior with avoidant personality disorder. So it really doesn't stand out. If we compare this to the behavior we see with cluster B personality pathology, so antisocial, borderline, narcissistic, and histrionic personality disorders, we see that pathology is really associated with behavior that's easily detectable, like anger, criminality, arrogance, and boundary violations. AVPD doesn't have any of those features. The misperception about this disorder continues, but it really needs to be taken seriously in the mental health treatment community. It is a serious disorder that affects a lot of people, and we need to develop a better understanding of it in order to effectively treat it. Now, one of the areas that really complicates the understanding of AVPD is comorbidity. And the disorder that really stands out as being highly comorbid with AVPD is social anxiety disorder. I'll refer to this disorder as SAD. We see that among people who are diagnosed with SAD, 46% have comorbid AVPD. The relationship between these two disorders is often misunderstood or poorly understood. There are a lot of theories about it. We see that one theory is that there's a continuum involved here. This is called the Continuum Hypothesis. Both disorders have clinical representations of social anxiety, but AVPD has more severe impairments and symptoms, including potentially a lack of insight. So we would not expect to see a lack of insight with just SAD. There are other theories, though, as well, including the idea that these two disorders are really different categorically, like they belong in different categories, not on a continuum. This is supported by the idea that AVPD has characteristics that we wouldn't expect to see with just SAD, like that sense of inferiority, being passive, and demonstrating restraint in romantic relationships. Those seem to point to AVPD, and they don't have a clear relationship with social anxiety disorder. In terms of comorbidity with other mental disorders that are not personality disorders, so other than SAD, we see that avoidant personality disorder is highly comorbid with obsessive compulsive disorder, generalized anxiety disorder, panic disorder, major depressive disorder, and bipolar disorder. So what about AVPD's relationship with other personality disorders? Well, personality disorders are interesting in many ways, including the area of comorbidity. If somebody has one personality disorder, they are likely to have at least one other personality disorder diagnosis. For example, if somebody has narcissistic personality disorder, they are at a greater risk to have antisocial personality disorder. Looking at AVPD, we see that 59% of individuals with dependent personality disorder also meet the criteria for avoidant personality disorder. We know that avoidant personality disorder is often comorbid with obsessive compulsive personality disorder and all 3 of the cluster A personality disorders, so paranoid, schizoid, and schizotypal personality disorders. We also see comorbidity between avoidant personality disorder and borderline personality disorder, which of course is a cluster B personality disorder. And this just reinforces this idea about how AVPD gets dismissed so often, right? It gets viewed as a disorder that's just not that serious. If somebody has AVPD and a cluster B personality disorder, the cluster B personality disorder is going to be the focus of treatment most of the time. Now, an area of personality that really gets misunderstood with AVPD is this idea that people with this disorder don't want contact with other people. They don't want close relationships. This is confusing AVPD with Schizoid personality disorder, SPD. Individuals with AVPD desperately want relationships, and specifically they want close, intimate relationships with other people, right? So that's often misunderstood with this disorder. Now, another clinical feature of avoidant personality disorder that points to marked impairment is the high stability of the avoidant features over time. Symptoms like the fear of negative evaluation, the patterns of social inhibition, and feelings of inadequacy tend to stay around as people grow older. Interestingly, however, there is another school of thought, and that is that the personality characteristics of this disorder are not particularly stable, right? So we see mixed results in the research literature. There's this idea that maybe they demonstrate the same level of stability as the SAD characteristics. So this points back to that Continuum Hypothesis. Maybe SAD and AVPD are really just 2 points on the same continuum. So it's always tricky when you're working with mixed results, but I would say in my experience, the characteristics are fairly stable over time. But either way, we see a lot of interesting theories. Now, another interesting and somewhat controversial theory is the idea that AVPD may be on a continuum with Schizoid personality disorder, again, SPD. Some of the support for this theory comes from the research we have on AVPD and schizophrenia. We know from this research that symptoms of both disorders tend to aggregate in the same families. And of course, Schizoid personality disorder is related to schizophrenia. So there may be a connection between AVPD and SPD. Of course, the comorbidity between AVPD and the cluster A personality disorders also lends support to this particular theory. Now, this is a compelling theory. We know that social anhedonia, that's a lack of pleasure in social situations, is predictive of schizoid personality features, and internalized shame predicts avoidant personality features. So what really appears to distinguish these two disorders is that individuals with schizoid personality features lack a desire for close relationships, and individuals with avoidant personality features strongly desire relationships. I mentioned that before. So both disorders are associated with not having those close relationships, but for very different reasons. Somebody with AVPD is actively detached, and somebody with SPD is passively detached. Interestingly, this categorical conceptualization of avoidant and schizoid features holds up much better for men than for women. We see in studies that women are more likely to present with a blend of schizoid and avoidant traits, whereas men tend to be in one category or the other. So they have avoidant features or schizoid features, but it's not often that they would have both. So there may be some gender differences to consider when looking at the controversy between these two disorders. So that takes care of comorbidity, but what about etiology? Etiology is the study of what causes disorders. So what causes AVPD? Well, whenever we look at etiology, we usually break it down into two categories: heritability, that is genetic influences, and environmentability, that is stress, the stress of the environment. The heritability of AVPD is around 64%, so it has a larger genetic component than we see with most personality disorders. If somebody has a first-degree relative who has social anxiety disorder, they are 4 times more likely to develop AVPD. There are, of course, environmental stressors that may lead to the disorder as well. The one that really stands out in the research literature is neglect. We see this repeatedly. So neglect appears to contribute to AVPD as well as a number of other personality disorders. So we know what it is, we know the definition, and perhaps we understand some of the comorbidity and what leads to it. But how do we treat avoidant personality disorder? Many of the treatment strategies for this disorder are actually based on social anxiety disorder. So we don't see a large number of studies that specifically focus on AVPD treatment. This may not be too problematic if these two disorders are really on a continuum, but if they are categorical, individuals with AVPD might not be getting the most targeted treatment possible. So this could be a bit of a problem. The most popular treatment for social anxiety disorder, and consequently for avoidant personality disorder, is cognitive behavioral therapy, CBT, We see a few studies showing that this therapy is reasonably effective. Some estimates say that about 40 to 65% of the individuals with AVPD who receive this treatment would no longer meet the diagnostic criteria after 1 year. So at first, this seems really good, 40 to 65% in a year. That seems promising. The difficulty here, of course, is the same problem that we run into when treating other personality disorders. We often see numbers like this when it comes to treatment effectiveness for personality disorders, but we also know from research that the personality characteristics tend to persist even if the observable behaviors are reduced. And of course, if we look at these symptom criteria, they're largely based on behaviors that can be observed, as opposed to internal states that may not be as obvious. For example, a person with AVPD may receive treatment, and then after treatment, they take a job where they're interacting with more people. They take more chances in romantic relationships, and they venture into new social situations, but they still feel inadequate. They're still afraid of being ashamed. They're still preoccupied with being rejected, and they still feel inferior and unappealing. So yes, one can make the argument that the behavioral change is positive, and I agree, it is positive. It's good that those behaviors are changed. That reduces impairment. It helps the person to function. But the underlying personality structure is usually not altered that much. That's the real difficulty with treating personality disorders, right? So we see behavioral change, but the tendencies and the feelings may not change as much as we think. So how the person processes emotions, right? So how they develop feelings is still really unaltered, right? So an emotion happens and they have this distorted lens, this lack of insight, and they develop feelings, again, of inferiority and feeling ashamed. So that process doesn't get interrupted that much through the application of CBT. The process that's changed is what the person actually does. Again, the behavior. So when looking at this type of balance, it just leaves us wondering why these treatments can't quite do the job, right? They tend to fall short. We're good at changing some things, but we're not good at changing other things. And I would say that if we could change the way people develop feelings, if we could change the personality characteristics, of course the behaviors would change as part of that, right? So we're really working on the wrong end of the problem in some conceptual way, but in another way, we're working on the only area where we can seem to make meaningful change. Even with all this in mind, though, treatment, of course, still makes sense. Counseling is a good idea. The behavioral changes are helpful, and there may be changes in someone's ability to regulate their feelings. They might not be able to change them as they kind of come up, but they may be able to regulate them better. And some change in personality may take place in certain cases. Again, that's the most challenging part to really change. Personality forms early. There are no late onset personality disorders. All personality disorders have an environmental etiological component that's based in childhood. Now, I know whenever I talk about disorders like avoidant personality disorder, there will be a variety of opinions. Please put any opinions and thoughts in the comment section. They always generate an interesting dialogue. As always, I hope you found my analysis of this topic to be interesting. Thanks for watching.